Okay, Assalamu alaikum. Good evening, everyone. Welcome to this session on Meet the Expert of the diabetes arm of the conference. First, I would like to introduce myself. My name is Mohammed Hassanain. I'm a consultant endocrinologist in Dubai Health Authority, and I have the pleasure to be in this session of the Meet the Expert with the presence of two good friends, Professor Ali Al-Ma'mari and Professor Andrew Bolton. We'll first start with Professor Ali Al-Ma'mari from Oman on the cardiorenal protection in diabetes. Professor Al-Ma'mari is a professor in Sultan Qaboos University. He graduated from Egypt and he trained in UK, and then he moved on to Oman, where he was instrumental in the development of the Oman Diabetes Association, as well as the development in Sultan Qaboos Endocrine Department, with lots of important engagements in the various endocrine and diabetes societies and research in the region. Professor Al-Ma'mari will discuss with us today about the cardiorenal protection, a very important topic nowadays in the field of diabetes. Abu Saif, over to you.
Bismillah ar-Rahman ar-Rahim. Good evening, colleagues. Happy to be with you today. And I would like to thank the organizing committee in the Gulf Association of Endocrinology and Diabetes for their kind invitation. And also I would like to thank my colleague, Dr. Muhammad Hassanain, for the chairman of this session, for his kind words. And without further ado, I'll start my presentation regarding cardiorenal protection in diabetes. There is no conflict in this lecture. An outline of this lecture, guidelines update, brief of SGLT2 inhibitor and GLP-1 rules in diabetes management, and review of cardiovascular trial with SGLT2 and inhibitor and GLP-1, and then a statement summary. The guidelines, we know that, colleagues, guidelines has changed since 2018 to recognize the result of the impressive result of the cardiovascular outcome trials. And according to it, nearly all the scientific guidelines recognize the importance of the cardiovascular outcome trial with some molecules. And I will go today initially with the ADA 21 guidelines. And we know that the first line therapy is metformin with comprehensive lifestyle, including weight management and physical activity. Then you decide which category is your patient. And if there is in the red side to the left, if there is indicator of high risk or established already atherosclerotic vascular disease or CKD or heart failure, then the choice is for you with two molecules. And you need to consider them independently of baseline hemoglobin. For example, even if hemoglobin A1C is normal, you need to consider these medication for your patient. So if there is atherosclerotic vascular disease already exists, or there is indicators of high risk, the choice is for you to start with GLP-1 receptor agonist with proven CVD benefit. If not available, contraindicated, or there is side effect of this drug, then SGLT2 inhibitor with a proven CVD benefit. A new category is another category is heart failure. If the patient has heart failure with reduced ejection fraction and defined by a left ventricular ejection fraction less than 45%, then the choice is SGLT2 inhibitor with a proven benefit in this population. The third category, if there is CKD, diabetes, kidney disease, and albuminuria, the preferable choice for in this population is SGLT2 inhibitor with primary evidence of reducing CKD progression, or SGL2 with evidence of reducing CKD progression in other cardiovascular outcome trial. If not available, or there is side effects, then you go to GLP-1 receptor agonist. Suppose the patient doesn't have all these and he is in the other categories, which is the category which have 3 columns. If there is compelling evidence to minimize hypoglycemia, still GLP-1 receptor agonist and SGL2 are 2 of 4 choices in addition to DB4 inhibitor and TSD. If there is compelling need to minimize weight gain or promote weight loss, which are common in patients with type 2 diabetes, as we know, most of our patients either overweight or obese, and sometimes actually over obesity, what we call. So the choice is for you GLP receptor agonist with good efficacy for weight loss, or SGL2 inhibitor. If the third column is the cost is a major issue, then TSD and sulfonylurea. And of course, to avoid inertia, you assess your patient response in every 3 months to add another medication till you reach your hemoglobin A1C target. So ADA 2021, very clear statement to the beneficial agent, add beneficial agent SGL2 inhibitor or GLP-1 receptor agonist in high-risk patient independent of hemoglobin A1C and metformin use. So regardless hemoglobin, even if you are reaching target hemoglobin A1C 7, still according to this recommendation, you need to put the patient in one of these molecules if the patient got atherosclerosis, heart failure, or CKD. There are so many cardiovascular outcomes after it's required by all medication of lowering glucose agent by the FDA since 2008. And they are the DB4 inhibitors, GL2 inhibitor, GLP-1 receptor agonist. And in this session, I will do my best to cover GLP-1 and SGL2 inhibitors. So we know that is glucose is filtered and then it is reabsorbed again in the glomerulus, then reabsorbed again in the proximal tubule. Nearly 90% will be reabsorbed from the SGL2 segment and another 10 from the SGLT1 segment. So by given SGL2 inhibitor, will bind to this receptor and prevent this process, leading eventually to glucose and sodium secreted into the urine. So there will be diuresis, natriuresis because we are excreting sodium, and glycosuria because secreting glucose, and also decreasing proteinuria, loss of protein. So that will lead with the fluid, decreasing the preload in the heart, and this will decrease the stress of the left ventricular wall, and eventually will reduce the afterload. Also, at the liver, these molecules will stimulate the release of ketone bodies, synthesis of ketone body, mainly the beta hydroxybutyrate, which will lead to increased ATP, and that will increase the myocardial function and energetics. In the kidney, it will lead to vasoconstriction of the efferent arteriole and vasodilation of the efferent arteriole, and that will lead to decrease intraglomerular pressure, and also will lead to sodium and glucose secretion in the urine. The first trial is EMBARG trial. In this trial, actually, empagliflozin, SGL2 inhibitor, has shown to reduce the primary base by 14%. And we define the primary outcome as death from CV causes, non-fatal myocardial infarction, or non-fatal stroke. This reduction came by reduction of by 38% reduction of cardiovascular death. In addition, as secondary endpoint, there was a reduction of hospitalization of heart failure by 35%. So in summary, in EMBERG trial, 3-point MACE was reduced by 14%, death from any cause reduced by 32%, and nephropathy was reduced by 39%, and renal composite was reduced by significantly by 46%. CANFAS program, in this program, canagliflozin also arm, there was a reduction of 14% of 3-point MACE. In addition, there was reduction of hospitalization positive by 33%. In DECLARE study, in DECLARE-TIMI 85, the dapagliflozin has reduced 3-point MACE by 7%, but that did not reach significant for superiority, and it was significant for non-inferiority, which means there was no significant benefit, but also there was no harm. First is cardiovascular trial, which is similar actually to the EMBERG study, in which ertugliflozin also did not show a significant reduction in 3-point MACE, and also, but it was also significant for non-inferiority. So no significant benefit, but there was no harm. CREDENCE study, this study is specifically in patients with diabetes with chronic kidney disease, and the primary outcome is set as end-stage kidney disease, or doubling of the serum creatinine level, or death from renal or cardiovascular causes. And in this study, canagliflozin reduced the composite by 30%. In DAPA-CKD study, the primary composite outstanding more than 50 estimated glomerular filtration decline, end-stage renal or cardiovascular death. And in this study, dapagliflozin reduced 39% relative risk reduction of the primary composite outcome. DAPA-HF trial, in this trial, this is involved patients with reduced ejection fraction. And they were diabetes and diabetics, and with reduced also estimated glomerular filtration rate. And this study, the primary CV death, heart failure hospitalization, or urgent heart failure visit. And we could see in this trial, there was a 26% relative risk reduction in dapagliflozin group as compared to the placebo. DAPA-HF also very clearly this improvement was in patients with diabetes and in patients without diabetes. So there was 27% relative reduction in in patients without type 2 diabetes, and with 25% relative risk reduction in patients with type 2 diabetes. EMPEROR reduced trial, in this was involved also patients with reduced ejection fraction and estimated glomerular up from 20 up. And in this study, the composite of cardiovascular death or hospitalization for worsening heart failure, and we see empagliflozin reduce that by 25% as compared to placebo. So in summary, colleagues, just to know the effect in 3 different outcomes in MACE, in cardiovascular death or hospitalization for heart failure, EMBERG was positive in the 3 components. CANFAS trial was significant in reducing MACE and reducing hospitalization for heart failure. It wasn't significant for cardiovascular death. DECLARE-TIMI was significant in reducing hospitalization for heart failure It wasn't significant for cardiovascular death or MACE, and similar to it, Fertis trial in was significant for hospitalization of heart failure. From the kidney composite outcome, there was different definition for the primary endpoint. However, all the trials, whether IMPAREG, CANFAS, DECLARE, and Fertis, reach significant reduction in the composite composite renal outcome according to the pre-specified definition. Now we go to the GLP-1 agonist rules and evidence, and I'm sorry for this quick because they have so many studies and I need to cover them all. We know that eating food will lead to stimulation of the GLP-1 hormone from the gut, and this GLP-1 hormone will lead to stimulation of insulin and decrease glucagon from the pancreas, will reduce appetite, and will slow down digestion. However, GLP-1 is inactivated within 2 minutes by DDP4 enzyme. So GLP-1 receptor agonists mimic the native GLP-1 and will improve this outcome. So the potential mechanism for GLP-1, it goes to the heart to increase the cardiac protection and mainly work through the pancreas, alpha cell decreasing glucagon secretion, beta cell increasing the insulin, increasing insulin biosynthesis, decreasing apoptosis, decreasing coagulation in the intestine, decreasing postprandial lipids in fast and other, decreasing the inflammatory brain, decreasing appetite, increasing satiety in blood vessel, decreasing the blood pressure in the kidney, increasing natriuresis and increasing diuresis. Leader study. In this study, actually, liraglutide has shown significant reduction in 3 MACE by 13%. And that benefit came from reduction of cardiovascular death with a 22% reduction. There was non-significant for non-fatal myocardial infarction or non-fatal stroke. Sustained study in which injectable weekly semaglutide has produced a 26% reduction in MACE as compared to placebo. And this reduction was mainly due to decreasing non-fatal stroke. Nephropathy also, there was significant reduction in new or worsening nephropathy with a hazard ratio 0.64, and this mainly come by decreasing persistent macroalbuminuria, which is significantly, which is the only significant in addition to new or worsening nephropathy. Rewind trial, in which this is trial, injectable weekly dulaglutide has significant effect by reducing 3-point MACE by 12%, with B value is 0.26. And this came also like semaglutide by reduction in the stroke incidence. For renal outcomes, there was significant in the composite, and this is mainly came from reduction in new macroalbuminuria with hazard ratio 0.77 and B less than 0.001. No significant for renal replacement and sustained decline in glomerular filtration rate. Pioneer study, which is oral semaglutide, have lower events in MACE. However, it did not reach significance for superiority, and it reached significant for non-inferiority. The other study is called Harmony study, in which albiglutide also have significant reduction of MACE by 22%. However, we should inform you that albiglutide is not anymore in the market, and it was withdrawn in 2018. There is some specific as two molecules actually. The significant reduction in MACE is due to reduction in stroke, which is sustained study, so semaglutide, and rewind study dulaglutide. The other, they did not. When in Pioneer study, they were often shouting to the right, actually increase. There was often, so the significance is decrease in risk of stroke in sustained study and rewind study. So to summarize for you, my colleagues, in 3-point MACE, that was positive, significant in leader study, sustained study, harmony, and rewind study. Cardiovascular death or hospitalization that was not significant or not reported in all the studies. Composite kidney outcome, there was significant reduction in leader study with liraglutide, sustained study with semaglutide, and rewind study with dulaglutide. Cardiovascular death was significant only in leader study with liraglutide. There was no significant or not reported hospitalization for heart failure. Dear colleagues, I hope I was able to cover everything related to all cardiovascular outcome trial in relation to SGLT2 and GLP-1. And in the summary, I report that both SGLT2 inhibitor and GLP-1 agonist are of proven benefit for patients with type 2 diabetes, and this benefit surpass the glucose control in patients with atherosclerotic vascular disease. The recommendation liraglutide, semaglutide, dulaglutide, and from SGLT2 inhibitor empagliflozin and canagliflozin. In the CKD, DABA, CANA, IMBA, and all others. For heart failure, DABA, IMBA, CANA, and all other also SGLT2 inhibitors. For stroke, there was significant reduction in stroke, where I'm talking about ischemic stroke, in semaglutide and dulaglutide. So I encourage implementation of the recent guideline recommendation in prioritization of this medication for at-risk patients with diabetes, regardless hemoglobin A1C. And with this, my colleague, with this view from Sultan Qaboos University, I thank you and best wishes with the remaining part of the Congress, and back to our chair, Dr. Mohammed Hassanein.
Thank you very much, Professor Ma'mari, for the comprehensive presentation. I encourage everyone to put their questions into the questions and answers section. And now, as we will have the questions at the end of the session, now we move to the second part of the Meet the Expert to the section of diabetic neuropathy. And when it comes to the update of diabetic neuropathy, there's no person globally than Professor Andrew Bolton to discuss with us the latest on diabetic neuropathy. Professor Bolton, I had the pleasure to know him very well for many years, working nearby in Manchester, and being an eminent diabetologist with huge research in the field of neuropathy and other diabetes complications, earning lots of awards and being the chair of the ESD and now the chair of the IDF, as well as the foot diabetes group. Professor Bolton, we look forward to your discussion on updates of the diabetic neuropathy.
Thank you very much, Mohammed. Always good to see you, and thank you for your generous words. And it's also good to see Dr. Al-Mamari from Oman, who I know well, and I enjoyed his talk. So you might say, like Monty Python, and now for something completely different. we're moving from the kidney and the cardiovascular system down to the lower extremity. And I'll talk to you about diabetic neuropathy, mainly about painful diabetic neuropathy. Now, this is an old slide of a paper review I wrote back in 1986, looking at the classifications of diabetic polyneuropathies and mononeuropathies. But today I'm going to focus almost entirely on chronic sensory motor neuropathy, the commonest variety, as I will show you. I don't have time to talk about autonomic or other neuropathies, but I will start with one case history I published when I was in Miami. The first time I was in Miami, when I had black hair, a young assistant professor back in 1983-84. And this was a case which emphasizes the importance of good clinical medicine, history and examination. This patient was eventually referred to me in the Diabetes Institute in the University of Miami. And he had been to see his primary care physician a few weeks before. And he said, I woke up one morning and I had a bulge in my side. And you can see, looking at this picture, he did. His GP looked at him and said, well, it's probably a hernia. So he sent him to a surgeon. And the surgeon examined him and wasn't sure. And he said, look, I really don't think this is a hernia. I think I'd better admit you for a few days for some investigations. So a few days later, after barium series from the top and the bottom, various endoscopies, IVP, ultrasound, the surgeon said, you know, I really don't know what's going on here, but I see you've got diabetes, so we'll ask the diabetes people to see you. Well, he did, and he came to me, and I said, well, tell me about this. You woke up with a bulge in your side. Did you have any problems the day before or the night? He said, well, now you mention it. When I was turning over in bed, it was a little uncomfortable. The skin was burning when it touched the sheets. So this rang the bell that this could be a polyneuropathy or a polyradicular neuropathy. So then I examined him, and he did indeed have hyperesthesia and allodynia in this region here, and he had absent abdominal reflexes on the right side. So I thought this is probably an unusual presentation of a truncal polyneuropathy. These are usually present with very severe neuropathic pain. So the one test that was needed was an EMG, and this showed fibrillations and abnormal patterns in the muscles supplying these muscles here. So this was a diagnosis made by a history and an examination. And yet this patient had had tens of thousands of dollars worth of tests, even many years ago, of 4 days in hospital, etc. So the message here is always take a history and conduct a careful physical exam. So we know that the diabetic polyneuropathies, as you see here, are dying back, affecting the longest nerves. So they're dying back with symmetrical, length-dependent sensory motor neuropathy. And the darker red, the more involved. So this is progressive loss of nerve fibers on a distal proximal gradient. The lower limbs are more affected than the upper limbs because it's length dependent. And as you know, it's the strongest risk factors for foot ulcers and amputations in many countries. And about 50% of those with this sensory motor neuropathy will develop some painful symptoms. And it's associated with the other microvascular complications. Now, slides won't seem to move here. That's right. It's common. This is to show you how common it is. And this is a study from my friend Dan Ziegler in Düsseldorf, the Monika Kohrer Augsburg survey. And in this study, they showed that the neuropathy was found in up to just under 30% of patients. There was a noise in people with pre-diabetes and even the control population, and you must always take this into account. I'm having trouble with my slides. They won't. Right. This is a study we published a few years ago, or 10 years ago now. This is a large study in the community. So this is a community-based study in the northwest of England of a large number of patients, mainly in primary care. And we assessed neuropathy using a modified neuropathy disability score and a neuropathy symptom score. And we found that 1 in 3 had painful symptoms and about 1 in 5 had really significant symptoms and signs. And we found that neuropathy was more common in type 2 diabetes, which of course is the most common by far diabetes seen in your region. And the pain was described well by Dr. Pavey in London in 1887 of being of a burning and unremitting character. So it's the clinical picture of the diabetic neuropathies is one of symptoms or no symptoms. So it's a spectrum. At one end of the spectrum, you've got these people who have very painful symptoms, classic neuropathic symptoms, burning, the skin's on fire or it's freezing cold, difficult to describe because the pain is different to that they've experienced by a fall or a cut or a minor surgery, etc. And there's often allodynia, which is on examination when a non-noxious stimulus such as touch gives rise to a painful experience. Worse at night, and of course, this causes marked disturbance of quality of life. In the middle, you've got some patients, the majority, who have some symptoms and some signs, but not this very severe pain. And at the other end of the spectrum, you have those at risk of foot ulcers because they've lost completely the gift of pain, but they feel their feet are fine because they have no symptoms. So it should be obvious by now why we have to screen for neuropathy, because up to half of patients may have no symptoms at all, and if you don't examine the feet, you will miss the neuropathy. We've shown in several studies that the annual risk of developing a foot ulcer is 5 to 7% in those with established neuropathy compared to less than 1% in those with no neuropathy. This is the first ulcer. Recurrent ulcers, 30 to 50%. We need to screen for it because it's common. Over 50% of older type 2 patients will have evidence of neuropathy. We need to screen for it because painful symptoms can be treated. And we've also shown in a study 20 years ago that neuropathy is a marker for generalized cardiovascular disease. So this is painful neuropathy. It's a clinical diagnosis with a history of this pain. Symptoms may be present in the absence of signs in very early neuropathy. We need to assess the severity and frequency of pain using such as a graphic rating scale, for example, a numeric scale. We need to assess for depression and anxiety. These are common in patients with neuropathy. And it is a diagnosis of exclusion. You know, when I was working in Miami, they all get an EMG. So they come back to see me $250 poorer for paying for this. And then it says, this is a diabetic neuropathy, likely, but I can't exclude other causes. And I said, well, I told you that. The EMG confirmed what I told you. So it's a clinical diagnosis. So what causes neuropathic pain? There are many possibilities, especially in neuroma properties, ectopic impulse generation. The dying back nerve fibers are trying to regenerate, and this gives rise to release of small fiber stimulation going up and being expressed as pain. But also, we've been interested in glycemic flux. Could something be to do with the stability or instability of the blood glucose control? And this came when I was a very junior doctor in Sheffield with John Ward. And they just started home blood glucose monitoring about 1980. And I saw patients the first time with home blood glucose monitoring, and I said, can I see your blood sugar results? And several patients said, I don't need to check them regularly because I know if my blood sugar is too high or too low, my neuropathic pain is worse. So this was a clue. Could it be something to do with that? And here is the association between blood glucose flux or instability and neuropathic pain. We know that acute painful neuropathy, acute neuropathy, can follow periods of metabolic instability. We know that painful symptoms can improve with stable near-normal glycemia, and in experimental models, hyperglycemia reduces pain thresholds. So a sudden improvement of blood glucose control can precipitate neuropathic pain, such as insulin neuritis, but it's now caused therapy-induced neuropathy. And we've reported acute worsening of painful symptoms after a pancreas transplantation in people with diabetic nephropathy, simultaneous pancreas kidney, and you get sudden improvement of blood glucose control, leading to worsening of painful symptoms. And in an early study published nearly 40 years ago and done 40 plus years ago, we showed that periods of stability of blood glucose control in the early days of continuous subcutaneous insulin infusion was associated with reduction of the neuropathic pain on a graphic scale, 10 being the highest, baseline 7 down to 2, after 4 months of stable control. But we weren't able to prove that then. So 20 years later, in Manchester, we did a study with the advent of continuous glucose monitoring, and we were able to see if blood glucose flux instability swings from high to low was associated with more neuropathic pain. In this study, we took type 1 diabetic patients, all of them had neuropathy, and all of them had a similar deficit on neurologic exam. But half had painful symptoms and the other half had no painful symptoms. And in those days, we had the early, 20 years ago, the MiniMed Medtronic glucose sensor, and we were able to monitor their blood glucose or tissue glucose control. This is, if you remember, the early model 20 plus years ago, and this measures tissue glucose levels every 3 minutes for 72 hours. Here is an example of a sensor report of 24 hours of a patient with painless neuropathy. And you see, if you're in milligrams, that's 180 milligrams, 90, and that's 360 milligrams percent. These are millimoles, and the squares are the patient's blood glucose tests, and these correlate very well with the tissue glucose continuous monitoring. But what you see in here is the control is not brilliant, but it's not too bad, and it's pretty stable. As it says in the essays you wrote as medical students, compare and contrast. Here's a patient with painful neuropathy, and you see a completely different pattern with swings from high to low and all over the place and poorer control. So what we showed is in those that painful neuropathy, there were many more fluctuations to hyperglycemia, and not shown here, but also to hypoglycemia. Overall, the mean blood glucose was worse in the 24 hours or 72 hours in those with painful compared to painless. And the flux, the M value, fluctuation from the mean, was more than twice as high in those with painful neuropathy. So it may be that the first step in the management of painful neuropathy is trying to stabilize. It may be the stability that matters more than the actual level you achieve. Don't do it suddenly, improve blood glucose control, because you can make neuropathic symptoms worse. So when I was in Miami again, full-time, I had to, well, I didn't have to, I was asked to and accepted to write this statement or technical review on diabetic somatic neuropathy with, you'll know, Riaz Malik, who used to work with me and did his PhD with me, now professor. He may be speaking at this meeting in Doha, and with other colleagues from the United States. I have to say, this was like writing a thesis. It ended up as more than 100 pages or 30 plus printed pages. And this was followed by the first position statement on diabetic neuropathy that I co-chaired with Arthur Vinnick. And the summary here, this is the summary from the ADA position statement 2005, that diabetic neuropathy is a diagnosis of exclusion of other non-diabetic causes of neuropathy, of which there are many, that tight glycemic control, we know from DCCT and UKPDS and other studies, is the only proven preventative therapy. All patients with type 1 diabetes should be screened for neuropathy after 5 years and annually thereafter. But remember that type 2 diabetes, because of the asymptomatic hyperglycemic period of many years prior to diagnosis, can present with neuropathy. We were one of the centers in UKPDS. 13% of patients at diagnosis had neuropathy of sufficient severity to lead to risk of foot ulcers. So we need to screen patients with type 2 diabetes annually from diagnosis, and the clinical history and examination of the essential parts, quantitative sensory testing and electrophysiology may be useful in some cases, and that there are a number of evidence-based therapies available for symptomatic neuropathy. Now, the ADA asked me to chair the next position statement published in 2017, but I said we need some, somebody younger to take the chair, co-chair with me. And Rodica Potbashiri, originally from Timișoara in Romania, now a senior professor and assistant director of research at University of Michigan, Ann Arbor, she took the lead and co-chaired that with me. And we had 3 neurologists and 3 diabetologists on board, including Riaz, as you see there, looking very young. So this was the position statement of the American Diabetes Association. This is the most recent one. And we looked at various objectives, which I won't go through them all today, but I'll focus mainly on management of pain. But first, to teach simple and sensitive and cost-effective diagnostic steps for patients to diagnose neuropathy. There are all sorts of expensive tests you can do, but we said we don't need any of those for clinical neuropathy management. And our neurologists and diabetologists, we were all in agreement. We need simple clinical tests of vibration, reflexes, of pressure, of pain, etc. And then, of course, we have different levels of severity. And this is myelinated fiber density and serial nerve biopsies. And normal, you can see the progressive loss of myelinated fibers here. So progressive loss of nerve fibers. And it's shown here in a distal proximal gradient. The large myelinated fibers, of course, the motor fibers, and also those conducting the proprioception and vibration perception in the dorsal columns. And the diagnostic tests here, if you need to confirm, would be nerve conductions and quantitative sensory testing, but these are not necessary in day-to-day practice. The small fibers, the small unmyelinated fibers you see here, these conduct the sensations of pain and temperature. Historically, this can be invisible. So for clinical trials and research, of course, we need more accurate diagnostic tests, but most of these, including vibration, quantitative sensory testing, these are complex psychophysical tests and rely on the patient's concentration. So there is quite a variability. And this is one of the problems we have. And the take-home message is that diabetic neuropathy can be easily diagnosed using an appropriate history and targeted physical examinations with simple instruments. Now, it was Corrigan, famous for the Corrigan sign, the collapsing pulse of aortic incompetence, the Irish physician whose bust stands in the Royal College of Surgeons in Dublin. He said these words: the trouble with most doctors is not that they don't know enough, but they do not see enough. They look, but they don't see. And you don't need a lot of tests to tell you that this is a neuropathic high-risk foot. This is moderate to severe neuropathy. You can see here this pes cavus, the high arch here, prominent metatarsal heads, coin of the toes, dystrophic nails, and you can't quite see here, but small muscle wasting. So the clinical exam is so important. So we assess for neuropathy using monofilaments, vibration, pinprick, ankle reflexes, and you can use a composite score, occasionally QST and electrophysiology. The last objective of the position statement was to discuss evidence-based recommendations for pain management. Treating neuropathic pain. The FDA-approved drugs are pregabalin and duloxetine. Tapentadol has come under suspicion. It didn't do very well in the recent systematic review. And of course, it is an opioid, and I'll come back to that. So both duloxetine and pregabalin have level A evidence, multiple randomized controlled trials and meta-analyses to support their use in the treatment of neuropathic pain. They're both licensed, FDA and the European Medicines Association, and they're both recommended as first-line treatments by the European Federation of Neurological Societies, and they're both recommended by NICE in the UK. The results of the combo trial combining the two were really not very conclusive. Look, you might be interested to see this paper just published a few months ago. This naltrexone is a competitive opioid receptor antagonist. It was compared with amitriptyline in a randomized RCT, and it actually showed it was equally good with fewer side effects. Now, to use an opioid receptor antagonist is interesting, but of course, I just show you this for interest. It needs further confirmation in larger studies. Opioids have come into a bad press recently, and as you know, there are major lawsuits going on in the United States against the manufacturers of these drugs for their side effects and deaths in people with painful neuropathy and other conditions. So I think we need to be very careful, and we don't advocate the use of opioids routinely, and probably should only be used by a pain specialist. More recently, we've had the capsaicin patch, and here is a meta-analysis, a post-hoc analysis rather, of 2 large studies by Rainer Freinigen from Germany, who is well known in this area, and to see if these patches work. And they do work, but some people may need recurrent applications of these patches, which are long-acting. And most recently, in a paper just published this year again, is high frequency, that's 10 kilohertz, spinal cord stimulation. And this is a study, a randomized controlled trial published in JAMA Neurology, suggesting in 216 patients that this is a highly efficacious treatment. Now, it is, of course, invasive, only for severe painful neuropathy, not responding to the other agents. But I think this is something, and there are other studies ongoing that we need to be looking at. It may well be safer than opioids. And in this study, there were only really very minor side effects, despite the invasive nature of this. And this has to be done, of course, by a specialist, usually a pain specialist, an anesthetist or anesthesiologist, whatever you want to call them, or even a neurosurgeon. So here's the algorithm from the most recent physician statement. Is this pain due to diabetic neuropathy? Exclude other causes. If it is, assess comorbidities, potential for adverse events and adverse events with the drugs we might use, especially considering that many of these patients are elderly. So be careful what you choose. First choices can be the voltage-gated alpha-2 delta ligands, such as pregabalin and gabapentin. Gabapentin, remember, you need 3 times a day in a high dose. But be stepwise up titration, not sudden. You might use the SNRI inhibitors such as duloxetine, or I think there's still a place in some people for drugs such as amitriptyline, but not in older patients or those with a cardiac history. If patients can tolerate these, they're still effective drugs. If there is no clinically meaningful effect, we might switch to another agent, try combining, or be very careful with drugs such as tramadol or tapentadol or other drugs which have been proven in neuropathy but are opioids. Don't hesitate for severe cases to refer to a pain clinic. So let's end with this Chinese quotation: superior doctors prevent the disease. We can prevent neuropathy by good glycemic control from diagnosis, especially in type 1. Mediocre doctors treat the disease before it is evident. Inferior doctors treat the full-blown disease. Let's try and move at least from mediocre to be superior doctors. And finally, let me remind you that our IDF Virtual Congress is focusing on diabetes complications. It's open for registration. We have 3 parallel streams, one of which is on neuropathy and foot problems. We have a dedicated stream on COVID-19 and diabetes. And we will be launching the IDF Atlas, which is the up-to-date data on the prevalence of diabetes globally, on the first day of the conference, when we will have a special centenary insulin celebration symposium. So we look forward to, in quotes, seeing you. And the last real big meeting I went to was actually in Dubai. I remember last February, and perhaps it was an ominous sign that I was lecturing on February the 29th, which only occurs every 4 years. But I do sincerely hope I meet many of my friends in the Middle East before 2 or 3 years from now, and I'm sure we will next year. Thank you very much. Shukran, and nice to see you, Mohammed.
Thank you very much, Andrew. If I would ask Dr. Ma'amari to join us for the Q&A session. Let me start with questions to Professor Bolton. I know that you need to go to another meeting soon. So one of the questions coming through is asking about the role of pregabalin and duloxetine. Are they only for controlling pain, or do they prevent future pain? Do they affect the outcome, long-term outcome of neuropathy?
Unfortunately, these are effective agents, but they are purely symptomatic treatments. They have no effect whatsoever on the natural history of the disease. And of course, no drug is without a side effect. So we always start at a low dose, for example, 75. Or if there's renal dysfunction, be very careful with pregabalin, even lower dose. And up titrate very gradually. Most people need 150 or 300 BD. And the same.
Okay, thank you, Andrew. Another question to you. One of the attendees is asking about the old policy of 4 different drugs, starting with Tegretol, Trental for vasodilatation, vitamin B complex, and amitriptyline. Is that what you would do, or how would you start the therapy for painful neuropathy?
Well, first of all, let's dismiss vasodilators. I was at my X-ray conference yesterday looking at neuropathic feet, and virtually every patient has vascular calcification or thickening. So we know that vasodilators don't work in diabetic neuropathy. There's no good evidence to support their use. That's the first thing. Tegretol, one trial many years ago showed some benefit, but again, these drugs have side effects. Amitriptyline, a useful drug, and the other one you mentioned was what was the other one? You can't remember.
Vitamin B and amitriptyline.
Yeah. You see, okay, if you're living in sub-Saharan Africa, you have a number of people who are malnourished. But I think in our countries, people are not malnourished, they're the opposite. And we rarely have vitamin B deficiencies. Okay, if you're on long-term metformin, worth checking the B12, but we rarely see B12-induced neuropathy on metformin.
You've hinted, Andrew, to the glucose variability. And we sometimes specifically, I don't know how frequent you've seen this, newly diagnosed diabetics where they are significantly hyperglycemia and then they suddenly start to complain of pain, insulin neuritis.
Yeah.
How should you treat this? Is it just a matter of time and it will settle, or should they start also treatment for painful neuropathy?
Yeah, I mean, painful neuropathy due to therapy is being reported by Max Allenberg in the 1950s with sulfonylureas as well. So it's not the insulin. It may well be the insulin, but it may be endogenous, stimulated by sulfonylurea, it may be insulin. And the same with pancreas transplantation, but you can't do much about it in those you're not going to take the pancreas out once you've had a transplantation. So this is usually very severe pain, worse at night, disturbed quality of life. But the natural history is that the symptoms resolve within a year. What I would do in someone who you've suddenly improved the control, what I've done, and there'll never be proof that I'm right or that I'm wrong, is actually reduce the insulin, let the blood sugar, let it run a bit higher, and then gradually reduce it. It's the speed of reduction. And we believe that its sudden improvement leads to reduction of nerve blood flow, which is increased in hypoglycemia and leads to localized ischemia, which brings on the pain. So gradually reduce the sugar. And if I've seen a lady, she came in, blood sugars were running, and I don't know if you're in millimoles or millimoles, say 20 or something, and they're suddenly improved, and they're all suddenly around 4 to 7 or below 100 milligrams per cent. And she got this most terrible neuropathic pain. I halved the insulin dose, gave her some pregabalin. You do need to treat the symptoms, but it's usually transient. The danger in our country, as you saw, Mohammed, is people get started on a drug, you get a repeat prescription, and 10 years later, they're still on it. Yeah. Review it after 6 months. Yeah. Polypharmacy, the best doctor is he that reduces therapy, not increases.
There's a question to you, Dr. Ali, about SGLT2 inhibitors, specifically about canagliflozin. From the evidence, I know that you've presented the information, but the person asking the question perhaps missed this. Does canagliflozin have evidence for cardiac protection as well or not?
Oh, yes, 14% results. It is the second one after empagliflozin. Very clear cut, actually. And the only issue with the canagliflozin, actually, when it came, that issue of amputation, and that really reflected for this drug. And it was removed now from that box regarding the foot amputation exceeding in patient with canagliflozin. But canagliflozin, one of the strong drugs, and credence also it prove again to say it's not only reduce the albuminuria, it's also reduce the hospitalization for heart failure. And
so to just reiterate what you presented, DAPA, EMPA, and CANA, the three are with very good evidence. Yeah. So at least we have three in the same category. So another question to you is regarding to the GLP-1. If someone is asking if the patient is not losing weight, and we know these drugs are expensive, would you switch to another drug, or what would you do?
Not losing weight. It depends what is the hemoglobin A1C level. I would like to know also if this is improved or not improved. if both, because in diabetes, we don't look only to one category, which is the weight, but also we look to the hemoglobin A1C and the other factors, and whether the patient have ischemic heart disease risk or doesn't have, because the category in which you prescribe this is not only for weight reduction. Now, if it's not, their weight is remaining the same and he doesn't have ischemic heart disease and he is not controlled in hemoglobin A1C, probably I look for other molecules and probably I go for SGLT2 inhibitor.
Andrew, if I were to ask you about two quick drugs, one of the attendees is asking about alpha lipoic acid.
I just replied to that in the chat box. It's not available in this country, but there is evidence that it may be helpful, and it's an antioxidant, and there is logic for using it. And it also may have some protective effect on progression of neuropathy if given in the early stages.
The other question was gabapentin. We know pregabalin preceded gabapentin, but if pregabalin is not available, I suppose gabapentin is be good enough.
Is equally good as amitriptyline with fewer side effects. But the problem is that the average dose in the trials was around 1.8 to 2.2 grams a day. And I used to see patients in Miami, 300 twice a day. I mean, you might as well give them a placebo. You need a good dose, and it's 3 times daily dosing. That's the problem. But it's still a useful drug if you can tolerate it.
I've noted in your presentation, Andrew, that you've mentioned several times the pain specialists, which unfortunately are not in abundance in our region. Do you want to comment on the role of the pain specialists in the severe painful neuropathy cases?
I think that we have a pain service in our teaching hospital, and that's run by an anaesthetist who has an interest in pain management. And this guy does for example, the spinal cord stimulation insertion of the leads. And they have a team with a psychologist. And I think they're very useful because complex assessment of these people with very severe neuropathic pain is absolutely essential. But, in some regions such as yours, it may be a neurologist with an interest in peripheral neuropathy might be a specialist on pain that might be helpful if you're really stuck as a diabetologist.
I think we've covered all the questions. It's been a very interesting session on Meet the Experts. I'd like to thank Professor Andrew Bolton very much, and my very good friend, Professor Ali Ma'amari as well, for their excellent session. And to stick to time, we'll close the session now.
We'll see you all tomorrow.
Thank you very much.
Bye.
A pleasure. Thank you. Thank you, Dr. Muhammad. Very impressed. Thank you.